This talk will be on congestive heart failure and its pathophysiology. Congestive heart failure is the common end pathway of all chronic progressive disease. There are many causes of it. You always start with the commonest 80%, the commonest 3 to 5 diagnoses, plus whatever acutely urgent things you can't afford to miss. And you don't worry about the comprehensive list. So if you say, what are the commonest causes of congestive heart failure? Number one cause by far is going to be ischemia. Ischemia is going to break into two groups. It's going to break into the artery with atherosclerosis and the arteriole with arteriolosclerosis. After that, we do less common things like hypertension and valvular heart disease. And these three together account for about 80% of all the causes of congestive heart failure. Now, there certainly are much more infrequent causes, and we could do the long list if we wanted. It would include all the causes of a dilated cardiomyopathy. It would include the restrictive cardiomyopathies, including alcohol and iron. And it would include the high output cardiac failures that you can see with anemias and arteriovenous malformations. But for an everyday working list, ischemia, hypertension, and valvular abnormalities are going to be the commonest things that you see. So the definition of congestive heart failure is surprisingly ambiguous. Most people will say it's when the heart either doesn't pump the blood that it receives, or it doesn't pump enough blood for the demands of the tissue. And that's all well and good in theory, but there's no practical way to measure that. So most of the working definitions of it will be an increase in left ventricular end diastolic pressure or left ventricular end diastolic volume. And that becomes much more like we think of the physiology that we learned when we were doing our physio class. Because end diastolic pressure, here with the P, that's much more like the isotonic or afterload pattern of cardiac reflex that we learned and correlates with end systolic volume. That's very different than when we talk about end diastolic volume, because that's what's going to correlate with the physiologic isometric stretch or the preload of the Frank-Starling curve, and that's going to correlate with our end diastolic volume. So those are our two good parameters. They correlate very well to how we think about the physiology of the stretch and the afterload, and correlate to two measurable parameters, end systolic volume and end systolic pressure. The one physiologic characteristic of the heart muscle is that one gets a fixed length proportional to the fixed load on the heart. That means that the size of our chamber is going to be determined by the afterload and not the stretch. How does the body know that the heart is failing? When we have congestive heart failure with its decreased cardiac output, how does the body know? And we come now to the essential pathophysiologic parameters that we're going to use for the rest of medicine and all of time. It knows that there's a decreased cardiac output because it has baroreceptors. And so we talk about the baroreceptors of blood pressure equals cardiac output times total peripheral resistance. Now, obviously, most of the time you're not going to see blood pressure. Instead, what you're going to see from the physiologist is mean arterial pressure. But that really doesn't say anything different, because remember, we spend 2/3 of our time in diastole and 1/3 in systole. If we want to convert blood pressure to mean arterial pressure, you take 2/3 of the diastolic pressure and 1/3 of the systolic pressure, and that will give you mean arterial pressure. Remember that when we talk about total peripheral resistance, here we're talking about our peripheral arterioles. And these are under control both of our smooth muscle and its interaction with the endothelial cell. This is under both neurologic, hormonal, and local control. The other parameters that we're going to use consistently when we talk about cardiovascular disease is the cardiac output here equals heart rate times stroke volume. And then the third of our major formulas is that stroke volume is proportional to preload, afterload, and to contractility. If we're going to go to what the baroreceptors measure, which is blood pressure, and they want to correct for that, They're going to have to correct the parameters of heart rate, stroke volume, preload, afterload, and contractility. Well, when we talk about the baroreceptors, there are three major areas that we see them. So you can see I've sketched in a diagram here of our heart, of our aortic arch and our carotid sinuses, and of our kidneys. So when we're talking about where are the centers that we measure pressure, well, the head, because it's a very privileged area and because it's got all of that hydrostatic pressure, the head is going to have baroreceptors that measure its both in the aorta and in the carotid sinuses. And these are going to signal the medulla through the afferents of cranial nerve 10 and cranial nerve 9. The second place that's measured pressure is going to be here when we talk about how we have a nephron, and it's going to form our macula densa that's going to interact with the blood vessels coming into and out of the glomerulus, and that's going to be our juxtaglomerular apparatus. So that's our second big center. And then our third big center is going to be here in the atria, which is going to be our atrial antirenetic peptides. These are going to measure a decrease in pressure both in the arches and in the kidney, and the atria is going to respond to increased stretch when there's hypervolemia. So how then does the body respond when it detects a decrease in blood pressure? It's going to respond neurohormonally. And what we're going to do now is we're going to draw a complex diagram. And I want you to draw this diagram with me, because this is a fundamentally important diagram, and it raises a number of important issues of learning. First of all, if you can't draw it, you don't know it. The second is we're going to use this to plot all our drugs when we come to treat congestive heart failure. And the last is we're going to track this blood pressure response, our neurohormone response, all the way through to our intracellular responses. And that's our third important idea of learning, which is completeness. So let's start now with the response to a drop in blood pressure, which is going to be the baroreceptors in our aortic arch. We're going to have baroreceptors both in the aortic arch and in the carotid sinuses. And as we just discussed, these are going to track to the brainstem through the afferents of the vagus and the glossopharyngeal. Here's my brain. This then is going to be my thalamus, and then we're going to come to a midbrain, and then I got my pons, and then I've got my medulla, and then I've got my spinal cord. And these nerves are actually going to go to the nucleus tractus solitarius. And the nucleus tractus solitarius is then going to signal two different parts of the medulla. There is the vasomotor, which is going to be the sympathetic system, and there is the cardioinhibitory, which is the parasympathetic system. So in this case, it's going to be hypotension, so it's going to increase sympathetic output. The sympathetic system is from T1 down to L2. So I'm actually going to draw it in. And then up here, these would be my cervical ganglia that I'm going to need for Horner syndrome. Then the sympathetic system is going to be signaled through the acetylcholine, and then it's going to signal the end organ with norepinephrine. Of course, the one exception to that is the sweat glands of the palms and soles. They have acetylcholine, and of course, it just goes straight to the adrenal and signals the medulla. But otherwise, we think of it as going acetylcholine to the sympathetic chain, and then norepinephrine becomes the signal after that. So with this massive sympathetic input, we're really going to be signaling three major organ systems, all the way to the molecular level. So the first of these is going to be my kidney. The next is going to be my adrenal medulla. And then the third is going to be my heart. And in the heart, we're really looking at two different centers, SA node, and we're looking at the myocyte. When we talk about sympathetic input to the kidney, we're talking about the nephron. And these are the segments of the nephron that you need to have, right? So there's my glomerulus, my proximal convoluted tubule, my loop, my thick ascending limb, my distal collecting tubule, and then my collecting ducts. And the sympathetic input goes straight into the juxtaglomerular apparatus. And sympathetic stimulation of the juxtaglomerular apparatus is going to go, renin is going to activate angiotensin 1, and then ACE is going to activate angiotensin 2, which has both local and systemic effects, and in the adrenal gland it's going to produce aldosterone, so that's going to give us our RAS system. When we talk about the adrenal, it's going to go to the medulla, which is going to produce catecholamines, which are going to be 80% epinephrine and 20% norepinephrine, and these are mostly going to affect the vasculature. And on the vasculature, they're going to affect the alpha-1 receptor. Well, if I was going to do a smooth muscle, I would have my alpha-1 receptor, which is a 7G coupled, and it is a GI receptor. Remember, GI is going to activate phospholipase C, which is going to produce IP3 and DAG. And DAG is going to increase the voltage-gated calcium channel input, and it's going to activate protein kinase C, and all of that phosphorylation is going to improve the sequences. IP3 is going to go to the smooth endoplasmic reticulum and cause an increase in calcium. So we've got two increases of calcium, one from the voltage-gated and then the other from the smooth endoplasmic reticulum. And calcium plus calmodulin is going to activate myosin light chain kinase, and that is then going to take ATP and it's going to recock the heads of my myosin. So they're ready for contraction. And when they contract, then that artery is going to become much smaller, and remember that flow is proportional to R to the fourth. So that's going to give me vasoconstriction. And then the last system that's going to be affected is going to be the heart. And the heart's going to be affected in two different areas. One is going to be the SA node, and the other is going to be the contractility of the myocyte. The SA node is going to be stimulated on its G-coupled beta-1 receptor, which is a GS. GS activates adenyl cyclase, which produces cyclic AMP, which activates protein kinase A. And protein kinase A changes the various transporters of the electrolytes and affects the periodicity of the firing. And so automaticity, remember, starts with a minus 60 millivolts with a threshold of minus 40, and there's a natural drift up through the IF, or funny channels, and when it hits threshold, we get the pumping of the calcium, the restoration from the potassium, and we've got a pulse. When we talk about what the effect of the protein kinase A is, it changes it so that we decrease the threshold and we increase the upper drift, and so that's going to increase our heart rate. The second thing that it's going to do is it's going to affect our myocyte. Again, it's going to be a G-coupled beta-1 receptor, which is a G-stimulatory. So again, we're back to our adenyl cyclase, cyclic AMP, to protein kinase A. But what that's now going to do to our cell is change the amount of calcium in the cell. So remember, we have our voltage-gated calcium channels, and the depolarization is going to let the calcium come into the cell. And there in the smooth endoplasmic reticulum, it's going to affect the ryanodine receptor, and that's going to release abundant calcium. So we have calcium-induced calcium release. And that calcium then is going to go down, and it's going to affect our troponin C, which is going to allow contractility. And then that calcium is going to be pumped back into it by the smooth endoplasmic reticulum calcium ATPase, which is regulated by phospholambda. Protein kinase A is going to increase the amount of calcium from the voltage-gated channel, increase the amount of calcium pumped by circa so that there's going to be more stored, and it's going to inhibit the inhibitor phospholambdin. All of this is going to increase intracellular calcium, which increases contractility. Let's go through our various parameters and let's take a look at how they're going to restore blood pressure. We've got to add one more action that we left off here, which is angiotensin II, also is a vasoconstrictor. Let's go through now and talk about how all of these, using the formulas that we've got, restore blood pressure. Blood pressure, which is what we're trying to restore, equals cardiac output times total peripheral resistance. Cardiac output equals heart rate times stroke volume, and stroke volume is proportional to preload, afterload, and contractility. Here we can see what all of these are going to do. When we come to the heart, we can see angiotensin II is going to increase our afterload. In addition, it's going to give us aldosterone, and aldosterone is going to increase sodium resorption at the collecting tubule, which is going to increase our intravenous volume. So intravenous volume is going to increase our preload. When we talk about our afterload, we can see that that's what our epinephrine is going to do. So afterload, angiotensin II and the epinephrine. Contractility is calcium, so we can see our contractility is going to be increased by our epinephrine, both neural and hormonal. Epinephrine going to increase our heart rate, and we can see that the epinephrine and the angiotensin II are going to increase our total peripheral resistance. So when we talk about the neural hormonal reaction to decrease cardiac output leading to hypotension, this then becomes the mandatory way of seeing it. And you notice we can take this all the way into the cells, which is by definition completeness. And when we get to the treatment end of congestive heart failure, we're going to put all of our drugs on this because all of the drugs affect neurohormonal treatment. Well, if this neurohormonal signaling is sustained for weeks to months, then we get compensatory hypertrophy of the myocyte. And this is collectively called remodeling. And remodeling is driven by Laplace's law. And Laplace's law in the heart says that the wall stress of the myocardium is proportional to the pressure in the chamber times the radius or diameter of the heart divided by the thickness of the wall. And if we're going to translate that into practical discussion, wall stress can really be summarized either by left ventricular end diastolic volume or left ventricular end diastolic pressure. And pressure in general can be calculated through blood pressure, with the exception of aortic stenosis. That's going to be before the actual pressure. When the heart experiences sustained increased wall stress and neurohormonal signaling, it remodels in two different ways. If there is an increase in afterload, then the myofibrils are going to expand in parallel. And what that means is if we take our myofibril and we talk about the contractile unit, which is the sarcomere. So there's my sarcomere there, and there are the actin-myosin units. And the sarcomere is defined as the space between two Z lines. Well, if we have increased afterload, which is due to things like hypertension and aortic stenosis, then the response is going to be to increase in parallel, which means we're going to add units this way. The ventricle is going to go from this to this. It's a much thicker wall, and as we increase thickness, that relieves the pressure. Now, one of the things you should notice is it doesn't actually mean you get cardiomegaly, does it? But you do get a smaller lumen, and so stroke volume becomes an issue, and the thickness of the wall means blood supply and diffusion becomes an issue, but you have relieved the pressure of the wall. The second pattern of response is if there is an increased preload. something that we're going to see in increased blood volume, like end-stage renal failure, or with regurgitation of the valves. And now what we see is if we have our sarcomeres this way, the heart responds in series, and so the fibers get longer. Now our heart is not going to get thicker, but the heart is going to mostly dilate. It will be somewhat thicker, but it's a dilated heart. And so because of the shape of the heart, this is called concentric hypertrophy, and this is called eccentric hypertrophy. All of this signaling, both from the sympathetic system, which is neurohormonal, plus an increased number of cytokines, TNF, IL-1, IL-6, cause problems because they lead to fibrosis and apoptosis. Fibrosis means you've lost contractility, and apoptosis means you've got fewer cells so that the others are under even increasing stress. And so when we talk about what happens if we don't correct the underlying problem, then the patient is going to go into irreversible progression and death. So when we come to talking about the treatments, we always want to differentiate those treatments that are only fixing symptoms versus those that are increasing lifespan. Because the drugs that increase lifespan are going to diminish the sympathetic and the cytokine effects on the heart. And that's the subject for treatment of congestive heart failure.